This presentation is a review of family-based childhood obesity interventions by Tova Patterson-Boer for Dr. Ford, Health 610. Rates of childhood overweight and obesity in the United States have been steadily climbing for the last several decades. Overweight is medically defined as a BMI equal to or greater than the 85th percentile, and obesity is a BMI equal to or greater than the 95th percentile. According to a 2015-2016 survey, the CDC estimates that 33% of children ages 6 through 8 and 36% of children ages 9 through 11 in the United States are considered overweight or obese. Elevated BMIs are associated with a higher risk for conditions such as type 2 diabetes, hyperlipidemia, and hypertension in both childhood and adulthood. The psychological impact of childhood obesity can also be quite high, as children may face weight-based stigma and bullying by peers, adults, and medical professionals. This can cause a decrease in self-esteem, self-efficacy, and mental health. Family-based obesity interventions have been shown to be particularly successful in addressing childhood obesity outcomes. Involving parents helps the whole family system change, thereby increasing the likelihood that healthy behaviors taught in the intervention will impact long-term change. Although these interventions have shown high success rates when presented in optimal test conditions, many require adaptations to fit real-world situations. This presentation will evaluate 3 family-based childhood obesity interventions and discuss what the research shows made them effective and what other considerations or adaptations would make them more effective. The 3 interventions are Bright Bodies, I Choose, and Better Health. It is worth noting that participation in Bright Bodies trial was paid for by Yale University, and the Better Health program is paid for by Australia's Universal Healthcare System. I Choose was the only program that required strict budgeting and payment from participants. All 3 of these programs are designed using a 3-pronged system, incorporating nutrition education, behavioral modification, and physical activity. The structure of how these are delivered varies depending on the intervention. However, the components are similar. All 3 interventions deliver nutrition education focused on creating healthy behaviors, not on enforcing a diet. Topics such as reading food labels, making healthy decisions at the grocery store, and how to put together a balanced meal are covered in this section of the intervention. The second section focuses on behavior modification, discussing items such as building self-esteem, setting goals, and creating healthy habits. The final section is spent on physical activity. Intervention leaders plan games, physical challenges, and sporting events for children and sometimes their parents. In evaluating these 3 family-based childhood obesity interventions and the adaptations that would make them more successful, attention must be paid to the overall program design. Low-income communities and communities of color are disproportionately affected by overweight and obesity. Many interventions are created with the assumption that these programs would be funded by health insurance providers and were created without a budget in mind. However, this is not usually the case, putting the burden of paying for the intervention on the low-income communities that they were created to help. Implementing an intensive intervention, such as Bright Bodies, is cost prohibitive for most communities to undertake. Therefore, less intensive programs are often more feasible. Research shows that a minimum of 26 intervention hours over a 2 to 12-month period are required to affect short-term effects on weight. 52 or more hours over that same time period are needed to affect change in metabolic risk factors and long-term health. Therefore, a middle ground must be found between intensive programs that are cost prohibitive and programs that don't have enough hours to affect change. Health literacy was another determining factor for success. All 3 interventions came with a workbook that was integral to learning and tracking new behaviors. Studies have shown that as the level of health literacy decreases, rates of obesity increase. This relationship makes it vital that the health literacy level of written materials be matched to the audience, not the program designers. I Choose was the only program that focused on this, making their written materials the most approachable to the target audience. Finally, the intended goal of the intervention impacts its efficacy and the way participants interact with the content. Bright Bodies determined success based on a decrease of participants' BMI. I Choose aimed at high parent engagement, and Better Health was a qualitative study focused on participants' enjoyment and dedication to the intervention. When put into a real-world context where participants are required to pay for involvement and are not held to strict attendance rules, parent engagement was shown as the best predictor of overall success. Studies found that if parents were invested in the intervention, They would likely attend dependably and participate. Participants across all three interventions discussed that nutrition education was most impactful when presenting new ideas or hands-on learning. Most participants already knew basic nutrition recommendations, such as eating more fruits, vegetables, and whole grains. However, they enjoyed discussing new ideas for healthy eating, such as food swaps or understanding food labels. Participants also noted that the greatest learning came from hands-on experiences. These experiences ranged from field trips to the grocery store, taking cooking classes, or group vegetable and fruit tastings. Parents were turned off when given basic nutrition information, commenting that they found it condescending. Participants also reacted well when the focus of nutrition education was on gaining health rather than losing weight. A 2017 study evaluated the psychological backdrop of family-based weight loss interventions and established that healthy self-esteem and well-functioning family relationships were strong predictors of intervention success. Conversely, those who entered the program with low self-esteem and/or dysfunctional family relationships were at a significant disadvantage in benefiting from the program. Because of this, the recommendation was made to incorporate self-esteem building in parenting classes as part of the intervention. This is especially important for participants with heavier bodies, as they may have faced bullying because of their size. Working to reverse or mitigate some of the damage done by this weight-based stigma has been shown to greatly increase the efficacy of an intervention. Family functioning is also an essential focus of the behavior modification component. Researchers found that there is often a family narrative about weight and size that parents and children carry. That narrative often doesn't serve them when pursuing their health goals. Identifying that narrative and working to create a new, more empowering story also strongly predicts intervention success. The physical activity part of the intervention has been described in polarizing terms. Many children enjoyed being able to play and develop physical skills around other people whose bodies looked and moved like theirs. Others described not being comfortable trying new physical activities and stated that this part of the intervention was their least favorite. Studies show that perceived motor competence, or the confidence in one's physical abilities, is developed at a young age. Regardless of actual motor competence or ability, this belief that one's body isn't good at physical activity becomes a self-fulfilling prophecy, often affecting willingness to try new things or progress in physical skills. Interventions that focus on building both actual motor competence as well as perceived motor competence were shown to be most effective. Greater perceived motor competence directly affects one's ability to enjoy physical movement. Research shows that the way that a program concludes is almost as important as the program itself when evaluating effectiveness long term. All three interventions had a set run time of 8 to 12 weeks. Once the program was over, there was rarely follow-up support, leaving families to continue on their own. Many participants across all three interventions have said that having an intentional transition out of the program would be more helpful. This feedback was particularly focused on physical activity. Outside of scheduled intervention meetings, parents had difficulty setting aside time to be active with their kids, as other life responsibilities competed for that same time. Children commented that it was hard to transition to physical activity with kids whose bodies were smaller or who had more body confidence. One participant commented that he enjoyed playing soccer during the intervention, but when he tried to play at recess, the kids teased him because of his weight. Re-entering a world of weight-based bias made many participants stop trying to be active for fear of being bullied. Family-based obesity interventions can be highly effective long-term because they address areas of nutrition, behavior, and activity. However, these programs are often expensive to run and cost-prohibitive for participants. In order to create a program of the highest value, research shows an emphasis on mental health and behavior change would have the most impact on outcomes. By focusing on creating strong family systems and building self-esteem, families can more easily act on the nutrition best practices that they already know. This, coupled with physical activity to build confidence and self-efficacy, could create effective change. Finally, building in a transition period from the intervention back to normal life may serve the participants well in continuing with new healthy behaviors. However, the biggest challenge is making these interventions accessible and affordable for populations most affected by childhood obesity: low-income communities, rural communities, communities of color, and those without regular access to medical care. For more information, please see these additional references used in creating this presentation.